So I'm going to go ahead and get started, guys, so that we don't get too far behind. I have the privilege of giving one of Dr. Curtis's talks here, so I will not claim to be nearly as important as Dr. Curtis, but here we go. And I'm certainly not that important. I don't have any of these disclosures. Personal disclosures. I am a faculty speaker for Medtronic, but I don't participate in any of these other things. So this is a talk that she put together. I went through the slides briefly this morning. This is a talk she put together in an effort to help out some of our primary care colleagues. There's some simplicity to this talk, but I think it's one of these that we're starting at the beginning for everyone. So obviously, feel free to interrupt me at any point if there's any questions or anything that I can help clarify. So pacemakers, mentioned up here at the very top, are used to treat bradycardia, arrhythmias. Implantable defibrillators treat tachyarrhythmias, or mostly ventricular arrhythmias, hopefully if they're working appropriately. But they also have a pacemaker function as well. And cardiac resynchronization therapy usually involves 2 or 3 leads, and is generally has a defibrillator associated with it, but can be on the setting of just a pacemaker as well. It is used for the treatment of heart failure. Patients with the following conditions are commonly indicated for a pacemaker. You see patients with symptomatic bradycardia, someone who just has a low heart rate. Everything else looks relatively normal, but the heart rate is just slow. Sinus node disease, or the common sick sinus syndrome. This is sometimes coupled with atrial fibrillation as well. So you have periods of time when the patient is going really fast, and then periods of time when the patient is going really slow. Unfortunately, the medications that we use to treat them when they're going really fast can make them go slower when they're going really slow, and most of these patients will end up with a pacemaker. Patients with a complete heart block, obviously, if the top part and the bottom part are not talking to each other, the heart rate tends to be on the slower end. And patients whose heart rate might be normal at rest, or with mild activity, but they know that when they increase their activity level, they're unable to modulate that with heart rate response. These are chronotrophically incompetent patients. And then all different levels of atrioventricular block. Any of these being symptomatic could, in fact, warrant pacing. So here's a pacemaker that Dr. Curtis has provided us a picture of. Here you see the pulse generator, which is the kind of brains and power source of the pacing system. Here you see 2 leads coming out that are a typical dual chamber pacemaker. The atrial port is typically in the top and the ventricular port at the bottom. Here one of the leads has an active fixation mechanism, so a screw mechanism, whereas the other one is a tying mechanism. If you send patients to the GPP service to get a pacemaker, most likely you will get an active fixation mechanism. This is always kind of a little bit trouble for some people. I'm sure the audience present today doesn't have any difficulty with this. But the modes of pacing. So you'll notice that when we send you a pacemaker, patient will say, oh, they're in DED mode, or they're in BBI mode. Or sometimes we get fancy and have these different modes that are kind of combined together. So what does this actually mean? Well, the first letter is the chamber that's paced, being either the atrium, which we can put in atrial pacemakers only, but that's a rare occurrence for us. Ventricle, which is designated B, obviously, or dual or both. The second letter here is the chamber sense, again, atrium, ventricle, or dual both. You can also have some special, specially denoted sense chambers here. O being, or 0 being none, which are some special cases. Sometimes we'll see a patient that's VOO, meaning that they're pacing the ventricle and not sensing anything, so they're going to constantly pace. The other is the response to sensing. So what happens when it senses? You can have triggered activity, which is a interesting programming. Sometimes we'll use that, but mainly what you'll see is either I or D following in the third position. I meaning that it inhibits. So the main job of a pacemaker is to sits the chamber that it's pacing, and pace the chamber that it's pacing. So inhibit mode would allow it to sense and not pace should it sense a native beat. Dual would allow it to do both. And then rate modulation is also present. There's some other multi-site pacing which typically aren't mentioned to you guys in our programming, but it is included here for completeness. So single chamber systems, one lead again, technically could be placed in the atrium by itself. It's not something that we typically do. At least in the United States, it's done not infrequently in Europe, but not here. And then ventricle, which is, as Dr. Curtis has pointed out, is the most common. The single chamber pacemakers are particularly used, especially the VVI mode, for patients with chronic incompetence or bradycardia who are in chronic atrial fibrillation. Here you see a VVI pacemaker. You'll notice that there's a paced spike here and a paced beat, followed by a sensed beat and no pacing. After the period of time when the patient's native conduction system is allowed to interject or interrupt the pacemaker timing cycle, you'll see another paced beat. Here you see an AAI pacemaker, same principle, that it's paced here and then it's continuing to sense the atrial rhythm after that. Most commonly, I would think most of the pacemakers that you would see would be dual chamber. In that case, there's one lead in the top part of the heart, the atrium, one lead in the bottom part of the heart. These leads can perform both tasks in each chamber, both inhibition and sensing and pacing in both chambers. And here you see a patient which is dual chamber pacing both the atrium and the ventricle, and they continue to do so. Sometimes you have the pacemakers, as Dr. Jackson has talked about, Dr. Prasad mentioned briefly as well, which are CRT devices or cardiac resynchronization devices. They either have 2 or 3 leads. Sometimes we only put 2 leads in our patients with chronic AFib. But the leads are used to sense all 3 chambers. The left ventricular lead is delivered through the coronary sinus, but you have an atrial, right ventricular, and coronary sinus lead. And the idea behind these is to provide resynchronization therapy for the ventricles. These are usually put in patients with wide left bundle branch blocks, but can be used for other reasons as well. So here you can see an example of a CRT system. You have an atrial lead and a ventricular lead, and it a little bit appears to be a unipolar coronary sinus lead present. But this is what a typical AP chest X-ray will look like for one of these patients. This is fluoroscopy, obviously, but this is what you would get in a straight AP view. So again, just to go through the components of the pacemaker, we have the pulse generator. Again, this is the brains of the unit, also contains the battery, and the electrical energy which is used to pace at the tips of the pacing leads in contact with the myocardium. Again, anode and cathode. We worry sometimes about having anodal or positive electric capture. But that's something we can sort out separately for you, but just so you know, that's the components of the pacing system. Here's a typical programmer. This one's provided by Medtronic. Each of the programmers are kind of are unique to each of the manufacturers. We typically use 4 manufacturers: Medtronic, St. Jude, Boston, and Biotronic. But the main components of each of the programmers are similar. Usually have a head or a wand, which goes over the pacemaker site, and a computer system here, which allows us to communicate and talk to the pacemaker, make changes, and see what the pacemaker's been doing. So again, as she mentions here, it's specific to each company. Patients typically carry ID cards. Sometimes patients aren't always great about carrying their ID card, but if they do, it'll tell you exactly what manufacturer they have and how you can best get someone to interrogate it. Also, I mean, if they don't have their ID card present, all the manufacturers, if you Google them online, will have a 1-800 number of some sort that you can call and inquire as to whether the patient belongs to that manufacturer or not. Again, it allows us to look at current programming and the behavior of the pacemaker, as well as institute changes in programming. Analyze lead and device function, and analyze any arrhythmias that might be present. These are excellent ways to pick up atrial fibrillation or ventricular tachycardia. So here's a typical printout from a Medtronic programmer. Again, all the manufacturers print these out a little bit differently, but sticking with the Medtronic theme that we've been using throughout this talk, this is from a Medtronic programmer. Here you can see at the top the pacing mode. Again, I know we just went through the pacing algorithm and you're like, what is that? That actually has 8 letters associated with it. But it's a special algorithm that Medtronic has come up with, which will help to minimize ventricular pacing, where you primarily try to pace in the atrium and allow the native conduction system to depolarize the ventricle. If that's not possible and the AV node is not working appropriately, it will switch to an EER mode or just an EEE mode if rate response is not programmed on. Here you can see the lower rate limit of the pacemaker. The patient's heart should never fall below that rate. So it will always be at a minimum 60 beats a minute. Then you can see the upper sensor and upper tracking rates. So in this patient, the highest paced beat that you should see is 130 beats a minute. That might not be the highest heart rate that you see, but the highest paced beat rate you should see is 130 a minute. And the lower rate is 60. Here you can see what percentage of time the patient is doing certain things, and most of the time their native conduction system is working on its own. There is a rarity of times where it's pacing in the ventricle, and then about a quarter of the time it's pacing in the atrium. You can see down here as well, it's contributing to A-phase, B-phase, almost 1% of the time. You can also see here where it's counting the number of PVCs that are occurring and how many have occurred in runs. If you prefer this in a histogram fashion, you can see at what rates the patient is paced or sensed. You can also see over here, we've kind of ignored it with this line here, but you can also see lead information here as well, what the current threshold is, and what the sensing is, as well as the impedance of the leads. So all the information that you kind of know. This is under something in Medtronic called Quick Look, and a lot of times we'll print out automatically as soon as the automatic interrogation is performed. So here's an ICD. It looks remarkably similar to a pacemaker. It's a little bit larger in size, and the lead itself is different in structure in that at the end of the lead, you'll notice a coil. This will look a lot larger on your chest X-ray as well. This is a device, obviously, as we talked about, that provides both pacing and defibrillation capabilities. So all current transvenous ICDs, again, as we mentioned, have pacing capabilities. There are anything from single, dual, to triple lead defibrillator devices when we start talking about cardiac resynchronization therapy. There's also a subcutaneous ICD. The only widely available subcutaneous ICD at this time is made by Boston Scientific. But while it also looks for ventricular arrhythmias, tachyarrhythmias, and will provide defibrillation therapy, it has, when I say it has no pacing capabilities, it does have very limited pacing capabilities for post-shock. However, it doesn't have any long-term pacing capabilities. Again, these devices, whether transvenous or subcutaneous, have demonstrated life-saving capabilities in these patients, as evident by some of the trials that Dr. Stein talked about earlier, made it to SCUD-HF, and then the subcutaneous ICD had its own feasibility trial as well. So again, indications for ICDs, as Dr. Sun mentioned, if you die or have sustained hemodynamically important ventricular tachycardia, ventricular fibrillation, you get a secondary prevention device. Primary prevention, however, gets into a little more work to determine if a patient needs a primary prevention device or not. Essentially, what it can be broken down into is if a patient has a cardiomyopathy with an EF of 35% or less and exhibits some symptoms from their heart failure, however, not class 4 symptoms, they would qualify for a primary prevention defibrillator. Again, class 1, so no symptoms at all, if they have an EF of 30% and the cardiomyopathy is determined to be ischemic condition. Then there's also questions regarding resynchronization therapy for patients with dysynchrony. So again, what she's labeled here is the bottom line. What does an ICD do? It senses cardiac signals. It detects dangerous rhythms. It does its best to detect dangerous rhythms and not shock inappropriately. More than just rate, there's certain algorithms that allow it to determine if a rhythm is coming from the ventricle or is actually an SVT coming from the atrium at a fast rate. And it provides therapy in cases if necessary. So provides the therapy of defibrillation should a tachyarrhythmia be determined. So detection, like we said here, detection of the arrhythmia occurs mainly based on rate. So you'll see that when we program these, we'll say you have a ventricular tachycardia setting or ventricular fibrillation setting at say 75 beats a minute or 200 beats a minute is what we normally program our primary prevention ICDs at, meaning that the defibrillation portion, the treatment portion of the defibrillator won't be activated until the rate reaches that. Even if they have a ventricular tachycardia below that rate, it still won't be activated until the rate crosses that threshold. So here you see an example of a shock. So to the left is a very fast heart rhythm. You can see this is delivery of defibrillation, followed by return to sinus rhythm with an occasional bass beat in there. So when you're doing your initial interrogation, like I said, when you put that wand over it, you'll look at the bottom right-hand corner, particularly if you're dealing with a Medtronic device, like the programmer that she showed earlier, and it will give you an alert. And if you click on that alert, it will tell you what's going on, that a shock was delivered. And many times you can see these EGMs, and it'll let you know if the shock was delivered. You can look at it and just determine if the shock was delivered appropriately or not. Here she's provided us an example of another type of therapy besides systolic shock called ATP, which is anti-tachycardia pacing. A lot of times when you're dealing with different BTs, particularly our ischemic BTs, these will be in a macro reentrant circuit, so something that you're typically used to when you talk about arrhythmias, and that you have this constantly circling arrhythmia. And if this pacing, which is done at a faster rate than the tachycardia cycle length here, can interject into that circular arrhythmia circuit there, that cycle in there, and interrupt certain refractory periods within the circuit, you can actually terminate that without a shock. So that's preferable to many patients. However, there are downsides to ATP as well. Here you see ATP which failed to convert a rhythm. And ATP again tried to convert a rhythm again. Unfortunately, one of the downsides to using ATP is you can actually accelerate the rhythm. So then the patient was converted with a shock, and actual fairly low energy shock that was successful, so that's probably good for that patient as well, but then converted with a shock. So shocks can be appropriate for rhythms coming from the bottom part of the heart, and inappropriate for rhythms coming from the top part of the heart. The most common inappropriate rhythm is atrial fibrillation, which can tend to push the ventricle pretty fast and cross that threshold that we talked about before for programming for tachytherapy. You can also have issues with the sinus tachycardia. Although we try to program our primary prevention ICDs in a manner that sinus tachycardia would be a rare reason to get shocked inappropriately. You can have lead malfunction. Of course, all you guys have dealt with patients with recall leads in the past, or at least know that this can happen. So lead malfunction can occur, even if the lead's not recalled. Lead malfunction can occur, and EMI, which is electromagnetic interference, can occur and cause a problem with the lead, and then it senses something that's not actually present. So shock for VT may have been life-saving. I like that she words it that way, because we learned that maybe all VT doesn't need to be shocked, but that can be a complicated discussion in and of itself. But again, getting back to some of our programming for primary prevention ICDs, we try to program it so that VT that doesn't need to be shocked doesn't get shocked. A single shock might not require any therapy. Remember, these patients had their ICD put in because they have a higher propensity towards sudden cardiac death than the average population, so that might just be an appropriate working of their device. But we can review the programming and detection of therapy and consider programming something that would prevent or at least lessen the need for shock in the future, if that looks like it's possible after looking at the EGMs. If shocks are occurring for other reasons, and such as you have a patient in VT storm, or there's a problem in our SVTs or ICD malfunction, and you want to turn the tachytherapies of the device off. One of the important things to know how to do is to place a magnet over the ICD itself. Now, I know that brings some hesitancy, and I've had it from our internal medicine residents and sometimes even more advanced trainees than that. This, on most, well, all of our modern ICDs, this will not inhibit the pacing therapies. So that's a key consideration. So if you have a patient that has both complete heart block or is pacer dependent and also has an ICD, you can disable the tachytherapies without disabling the pacing therapy. So that's an important point. So if you feel like the shocks are inappropriate and you want to make them stop, a magnet will not also stop the pacing, it will only stop the tachytherapies. And as she points out, however, the programmer is the surest way to do this. So to actually turn and change the tachytherapies with the programmer is the best way to make sure that doesn't happen in the future. Again, looking at patients with multiple shocks, this might be a sign of worsening heart failure ischemia, and they might warrant an ischemic evaluation or further medication titration. You can also consider antiarrhythmic therapies such as amiodarone and sotalol. I'd add mixilotine in there too, especially if you think it's an ischemic etiology. We could try that as well. If it's a monomorphic VT and something that we think we can go after, we can also consider ablation as well. So we talked about electromagnetic interference earlier, and these are some common sources. I don't know. I was reading here, it's all slot machines. I think there would be a fair number of dead people on the floor in Las Vegas if slot machines were a big problem with EMI. But there you go. I tend to tell patients not to keep their cell phone in their left pocket. But other than that, I don't usually worry about cell phones that much. But all these other things are kind of problems. The arc welding thing is an issue. I had a patient once that's kind of weld as a hobby as opposed to as a career. So that was an interesting conversation, and what we actually came up with was that he would only weld in short bursts, but he did not want to give up his welding. And it's usually industrial strength welding that's really the most problem. So here's an example of EMI. This is an interesting patient. I wrote the story for there's a presenter thing here, and she wrote the whole story of this patient. So this patient received a shock while using a soda machine at a triathlon. So this patient was passing out Gatorades using a soda machine and received a shock and woke up on the ground. And the thought process is that there was some kind of electrical leak from the soda machine. That's what they came up with as a final diagnosis, although they couldn't prove it and they couldn't recreate it. So there you go. Anything essentially can be a problem. But you can see here that this patient's in a normal rhythm. You can see a normal rhythm matching through here, and then this crazy high frequency signal, which is clearly not biologic, but is being sensed by the defibrillator, and finally gets to a point where it's sensed enough beats that it went ahead and shocked the patient. So ICDs and surgery is always an interesting concern because electrocautery, depending on how close it is to the defibrillator, can cause some problems, again, with EMI type things and inappropriate shocks. Of course, using the programmer is the best way, so disable the tachytherapies. That can be, you have to make sure, of course, that you re-enable the tachytherapies. Of course, within a certain period of time, the patient's device will, depending on the manufacturer, start either buzzing or beeping at the patient and let you know that the tachytherapies are not on. But it's still performed to let your patient get home with their tachytherapies off. The other thing, if that's not available, surgeries are emerging, is to use a magnet. Again, the idea of taking a magnet over the device will not inhibit the pacing, but will inhibit the tachytherapies while the magnet's in place. And then removing the magnet afterwards, everything should go back to normal. And this is talking about a patient, should a patient with an ICD receive a shock you should not be hurt. You should continue to, especially if the patient's in trouble and isn't revived on the shock, you should do ACLS as you would with any other patient. And defibrillation from an external defibrillator should not harm an ICD. I wouldn't put the patch directly over the ICD can itself, but otherwise it should not harm the ICD. Cardiac resynchronization therapy, and you guys have kind of had this in a couple different talks already. But again, it's providing or attempt to provide resynchrony to a dysynchronous situation within the ventricles. We typically use these for patients with left bundle branch block, typically with a QRS duration over 150 milliseconds. These are the people that tend to respond the best to CRT therapy. But there's other patients that have some lower end indications for CRT as well, which could be considered for CRT therapy also. Here's an example of the subcutaneous ICD that we were talking about. Again, this one's commercially available and currently is made by Boston Scientific. And everything within this system is truly subcutaneous, and nothing's within the vasculature, nothing violates the chest wall proper. So you have a device which is placed in the left axilla about midline, and then a lead which is tunneled over to just to the left of the xiphoid process, and then up the left side of the sternum. And this tends to provide a pretty good AP location for defibrillation. So in conclusion, Dr. Curtis's last slide here says that pacemakers are used to treat braided cardia or bradyarrhythmias. Again, we went over some of those. ICDs deliver both pacing functions, so patients that require pacing will have that from their ICD, but they also have the ability to terminate BT and BF through the delivery of shocks as well as anti-tachycardia pacing. Again, the sub-Q system has only the ability to shock and very limited pacing capabilities for shock only. And then cardiac resynchronization therapy is used to treat dysynchronous ventricular activation. Thank you.